For those of you who are not SAMBA members, please consider joining the society as it offers many benefits to its members. You can view a list of membership benefits on your screen now. Please visit our website, www.sambahq.org, to learn more about the benefits of membership. A few housekeeping notes before we get started today. Please note that this webinar is listen-only mode. As an attendee, your audio and video is off. On the bottom of your screen, you'll see two buttons displayed on the screen that you'll see right now. One that says chat and one that says Q&A. Please use the chat function to chat with other attendees during the webinar. However, use the Q&A box to place any questions that you have for our presenter. Dedicated time for Q&A will take place at the end of the presentation. Please submit your questions throughout so that we can prepare to answer them. SAMBA is on Twitter, Facebook, and LinkedIn. Connect with us on social media to stay up to date with all things SAMBA. Now, on to introductions. My name is Solmaz Nabipour. I am a clinical associate professor at Stanford University, and I'm also an anesthesia medical director at our Cancer Center Ambulatory Surgery Center. At this time, I would like to introduce our presenter. Tonight, we welcome Dr. Samuel Vanderhook. Dr. Vanderhook is an assistant professor in the Department of Anesthesia at Johns Hopkins University. He's an attending anesthesiologist in the Johns Hopkins Children's Center, and he provides anesthesia in the pediatric operating rooms, sees patients in the preoperative clinic, and is a member of the Pediatric Advanced Regional Team. Dr. Vanderhook's research lies in perioperative glycemic control, specifically in children and adolescents with insulin-dependent diabetes who use insulin pumps. He received his medical degree from Mount Sinai School of Medicine and completed his residency in anesthesia at Mass General, followed by a fellowship in pediatric anesthesia at Boston Children's Hospital. I will now turn things over to you, Sam.
Great, thank you so much, Dr. Nabipour. I'm just going to share my slides. All righty. So I'm thrilled to be here and to talk to you about a topic that's of great interest to me. I know what you're thinking. You know, do we really need to talk about taking care of a diabetic child? What else really is there to know? Give them some insulin, check a blood sugar, go on with your day. But stick with me on this because hopefully I'll be able to shed some insights about some of the nuances of this unique pediatric population and how best to care for them for outpatient ambulatory anesthetics. So we'll start with a case. My interest in the perioperative management of children with diabetes stemmed from a case of mine when I was maybe a year or two into being an attending. I had a 9-year-old male who presented for a fairly routine urologic procedure, a circumcision revision. His medical history was notable for type 1 diabetes mellitus, for which he had a continuous glucose monitor as well as an Omnipod insulin pump. So let's start with an informal poll. How would you manage this child's insulin pump for his anesthetic? Would you continue the pump at the patient's home settings? Would you discontinue the pump and start Lantus the evening prior? Would you discontinue the pump and start an IV insulin infusion in the operating room? Or would you continue the pump but reduce the basal rate to 50%? So I'll let folks mull this over for maybe 15, 30 seconds. And we'll see kind of where the audience lies when it comes to management of a diabetic child with a fairly standard regimen when it comes to his glycemic control. All right, so I think it looks like there's a split between continuing the pump or continuing the pump but reducing the basal rate to 50% of the child's normal basal rate. Looks like a third are on the continuing of the pump at the home settings, and then the remaining 2/3 are reducing it to 50%. Great. So we'll come back to this case at the end of this talk, but I think it's important to keep in mind a couple of things. So some things that popped into my mind when I first read about this case, and they were extremely basic questions, was what exactly is an insulin pump? What's a CGM? What does it stand for? Can I use these devices in the operating room, or do I have to remove them? And what are some strategies that I might be able to use to control this young man's blood sugar perioperatively? And can he go home postoperatively, or does he need to be admitted? So we'll come back to this case after we go through some data about perioperative diabetes management in the pediatric population. But some things that you might want to consider as we're talking is what would be your anesthetic plan? How would you manage the pump? What would be some strategies that you would have available for glycemic control?